My name is Chris Burke, and I am a pharmacist on the clinical team at Aegis Sciences Corporation. Today, we'll be discussing benzodiazepine drug testing, specifically how commonly used point-of-care tests compare with definitive laboratory testing. Benzodiazepines are widely prescribed, but they're also widely misused and frequently involved in safety events, particularly when combined with opioids, alcohol, or other sedating medications. The goal of today's discussion is not to criticize point-of-care testing. Instead, it is to help clarify what these tests can and cannot tell us, and how to use each testing method appropriately in real-world clinical decision-making. Here are the objectives for today. First, we will review key analytical limitations of benzodiazepine point-of-care immunoassays and why those limitations matter clinically. Next, we will compare point-of-care screening results with definitive LC-MS/MS testing. We will then look at clinical scenarios where discordant results have the greatest impact on patient safety. Finally, we will discuss practical strategies for incorporating definitive testing into patient care when it is most appropriate. Benzodiazepines are commonly prescribed for anxiety, insomnia, seizure disorders, and other neurologic or psychiatric conditions. Because they act on the central nervous system, they can cause sedation and respiratory depression, particularly when combined with other substances. Monitoring benzodiazepine use is important for confirming adherence, identifying undisclosed use, and assessing safety risk. This is especially relevant in behavioral health, addiction medicine, and pain management settings where overlapping sedating medications are common. Point-of-care benzodiazepine tests are the cups or cards commonly used in clinics and offices. They are widely used because they are fast, simple to perform, and provide qualitative results within minutes. These tests are often used as an initial screening tool to support near-term clinical decisions. Understanding how they work is important because before interpreting what the results mean. Most benzodiazepine immunoassays rely on antibodies that primarily detect oxazepam-like structures. As a result, several commonly prescribed medications, including lorazepam, clonazepam, and alprazolam, often show poor cross-reactivity. Non-traditional and designer benzodiazepines are even more likely to be missed. Test performance is also influenced by factors such as cutoff thresholds, timing of last use, and urine dilution. Because of these limitations, a negative point-of-care result does not reliably rule out benzodiazepine exposure. Definitive testing uses advanced laboratory techniques, most commonly liquid chromatography with tandem mass spectrometry. Rather than providing a class-based result, these tests identify specific parent drugs and metabolites. They operate at lower detection thresholds and include broader analyte coverage, including atypical and designer benzodiazepines. This makes definitive testing particularly valuable when results will influence clinical management or safety decisions. Unlike regulated benzodiazepines, designer benzodiazepines are non-traditional compounds that mimic the structure of standard benzodiazepines, but are not approved for clinical use. In this analysis, definitive testing identified substances such as bromazolam, clonazepam, flualprazolam, atizolam, diclazepam, and other emerging analogs. Many of these compounds are highly potent and may be unfamiliar to both patients and clinicians. They are frequently co-detected with opioids or other sedating substances, increasing the risk of adverse effects. From a testing perspective, these compounds are poorly detected by most point-of-care immunoassays, which helps explain the high rate of false negative screening results. To better understand how these testing methods compare, Aegis evaluated real-world urine samples that had both a point-of-care benzodiazepine result and a definitive LC-MS-MS result from the same patient encounter. These samples were selected because definitive testing had already identified designer benzodiazepine exposure. This allowed us to assess how often point-of-care testing detected or failed to detect those known exposures. This was a paired sample comparison using real-world clinical urine specimens. Each sample included both a point-of-care test and a definitive LC-MS-MS test from the same patient encounter. The analysis specifically focused on samples where definitive testing confirmed the presence of at least one designer benzodiazepine. This approach allowed us to directly evaluate how often point-of-care testing detected or failed to detect benzodiazepine exposure that was definitively known to be present. The goal was to understand real-world performance and clinical impact. By examining concordant and discordant results, we were able to assess how reliance on point-of-care screening alone could influence clinical interpretation, adherence assessment, and safety evaluation. This methodology reflects how testing is actually used in practice and highlights where gaps in detection may have meaningful consequences for patient care. One of the most important findings was that negative point-of-care results frequently occurred even when benzodiazepines were clearly present on definitive testing. Compounds most often missed include lorazepam, 7-aminoclonazepam, alprazolam metabolites, and designer benzodiazepines. These are not rare or theoretical cases. They reflect substances encountered routinely in clinical practice. This cohort included 48 samples with confirmed designer benzodiazepine exposure, all verified by LC-MS-MS. When those same samples were screened using point-of-care testing, only about 27% returned a positive result. In other words, only 1 out of 4 true exposures was detected by rapid screening. Another finding is that approximately 2/3 of confirmed exposures produced negative point-of-care results. A 66% false negative rate means that for every 3 patients who truly had designer benzodiazepines present, 2 were told the screen was negative. That level of misdetection is clinically significant. A negative screen may falsely reassure providers, affect monitoring decisions, or delay appropriate follow-up testing. In some cases, it can also create confusion or mistrust when confirmatory testing later shows a different result. We also observed a small number of inconsistent results across different point-of-care devices, which suggests variability in performance depending on the platform used. Overall, these data show that point-of-care screening alone is not reliable for detecting designer benzodiazepines. Without confirmatory testing, a substantial proportion of true exposures may go unrecognized, with real implications for patient safety. Many testing strategies rely on point-of-care results to decide when definitive testing is ordered. In this analysis, we evaluated a reflex approach, where definitive testing is triggered only by unexpected point-of-care findings. Using that strategy, only 31% of designer benzodiazepine exposures would have been identified. That means about 2/3 of true exposures would still be missed, even though a reflex process is in place. This creates false reassurance. A negative or expected point-of-care result can give the impression that risk is low, when exposure is actually present. As a result, patient risk may be underestimated, and opportunities for appropriate follow-up testing can be lost. Overall, reflex testing driven solely by point-of-care results leaves a significant gap in detection for designer benzodiazepines. Missed benzodiazepine exposure has meaningful clinical consequence in several scenarios. In adherence monitoring, it can lead to incorrect assumptions about non-adherence or diversion. In patients receiving opioids, unrecognized benzodiazepine exposure can significantly underestimate overdose risk. In behavioral health and addiction treatment settings, incomplete information can affect treatment planning and safety decisions. When exposure is missed, clinicians may have an incomplete understanding of a patient's overall risk profile. Polysubstance exposure patterns may go unrecognized. Safety concerns related to sedation or respiratory depression may not be identified until clinical consequences emerge. And recognizing these limitations helps prevent misinterpretation of screening results. Definitive testing adds value when identifying specific substances will change clinical management. It supports more accurate risk stratification and helps characterize complex exposure patterns. This alignment with the modern drug supply is increasingly important for patient safety. Test selection should begin with a clear clinical question. If results will influence safety decisions, treatment planning, or risk assessment, definitive testing should be strongly considered. In practice, this could mean ordering definitive testing up front in higher risk patients rather than waiting for an unexpected screen. Negative point-of-care results should be interpreted cautiously, particularly in high-risk patients. Patients may not realize that different drug tests provide different types of information. Explaining the difference between screening and definitive testing helps patients understand why additional testing may be recommended. Framing definitive testing as a safety tool supports trust and shared decision-making. Taken together, these findings show that negative benzodiazepine point-of-care results do not reliably exclude exposure. Designer benzodiazepines are frequently missed by standard immunoassays. And definitive LC-MS-MS testing provides a more complete assessment when used strategically in the appropriate clinical context. Point-of-care testing remains a useful screening tool, but it has important limitations. Understanding those limitations and knowing when definitive testing is necessary supports safer prescribing and better clinical decisions. A thoughtful, integrated approach to testing improves patient safety. Thank you for joining us today. If you have any questions about benzodiazepine testing or would like help selecting an appropriate testing strategy, please reach out to the Aegis clinical team using the contact information shown here.